Effect of pre-resection biopsy on detection of advanced dysplasia in large, non-pedunculated colorectal polyps undergoing endoscopic mucosal resection. Introduction. Large, i.e. 20 millimeters or more, non-pedunculated colorectal polyps comprise 2% to 5% of polyps identified in colorectal cancer screening programs. These lesions are pre-malignant and can be endoscopically resected. Owing to its efficiency, safety, cost, and clinical effectiveness, endoscopic mucosal resection, EMR, is an established treatment for large, non-pedunculated colorectal polyps. Pre-resection diagnosis is important in order to optimize treatment decisions, as a subgroup may contain early submucosal invasion and be unsuitable for EMR. Specific endoscopic imaging parameters can be used to assess presence of submucosal invasion in large non-pedunculated colorectal polyps. These include lesion morphology and surface microvascular and pit pattern. Routine pre-resection biopsy of large non-pedunculated colorectal polyps for histology is also traditionally used. However, whether pre-resection biopsy is useful in guiding treatment decisions has not been established by evidence. Therefore, the authors sought to assess differences in pre-resection biopsy and EMR specimen histology and the effect of pre-resection biopsy on EMR outcomes from the author's center. Methods. This was a retrospective analysis of a prospectively collected cohort of patients with large non-pedunculated colorectal polyps referred for EMR between 2013 and 2016 at an Australian tertiary center. Outcomes were differences between pre-resection biopsy and EMR histology and effects of pre-resection biopsy on the EMR procedure. Results. Among 586 large non-pedunculated colorectal polyps, lesions that underwent pre-resection biopsy were larger and more commonly morphologically flat or slightly elevated compared with lesions without pre-resection biopsy. Pre-resection biopsy histology was upstaged in 26.1%, downstaged in 13.8%, and unchanged in 60.1% after EMR. Sensitivity of pre-resection biopsy was 77.2% for low-grade dysplasia and 21.2% for high-grade dysplasia. Where EMR specimen showed high-grade dysplasia, pre-resection biopsy had detected low-grade dysplasia in 76.9%. Where EMR specimen showed cancer, pre-resection biopsy had detected dysplasia only. Pre-resection biopsy was associated with more submucosal fibrosis and intraprocedural bleeding. EMR success or recurrence was not affected. Conclusions. Routine pre-resection biopsy of large non-pedunculated colorectal polyp did not reliably detect advanced histology and may have affected EMR complexity. Pre-resection biopsy should be utilized with caution in guiding endoscopic management of large non-pedunculated colorectal polyps.